Okay. Good morning, everybody, and welcome to Implant Threads by VSSAcademy. My name is Alan. I'm from VSSAcademy, and today we have the pleasure of Dr. Owen O'Sullivan, who's going to be our tutor today. Before we begin, just a few pieces of housekeeping. If you would be so kind as to put your cameras on so that Owen can see who he's talking to, that would be fantastic. You're all currently, and throughout the presentation, you'll be on mute. If you have any questions, we will take them at the end. So if questions come up during the webinar, please type them into the chat section. So you'll see the chat icon at the top of the screen, and then you can just type in there, and then I'll pick up the questions at the end. So thank you for your time, and thank you for coming today. And I'm very, very pleased to welcome Dr. Owen O'Sullivan. Owen, over to you.
Thank you. Hi there. So yes, Alan has introduced me. My name is Owen O'Sullivan. I am a specialist in prosthodontics. I did my postgraduate training at the Eastman Dental Institute, and then I stayed on there for 15 years as a clinical lecturer, in particular with a view to teaching implant dentistry to prosthodontic specialist trainees. Since then, I've been very involved with teaching with the ITI and now with VSS. But my first love has always been practice, and I've been fortunate to be a partner at the number 8 partnership, which is a specialist referral practice in central London. We are celebrating our centenary this year, so yeah, we're a very old school, well-established practice. And I've been fortunate to have a lovely clientele of patients there who allow me to do dentistry the way I would like to be doing dentistry. So I consider myself very lucky. In the photograph on the right, you'll see my surgery. And for the more eagle-eyed among you, you will see in the corner a very old school scanner. So that was my first ever intraoral scanner, which I got over 15 years ago. And I've been very much involved with the developing of digital workflows in restorative dentistry and in particular in implant dentistry during that time. By means of a slight disclaimer, I am a key opinion leader for iTero. And so if there's a degree of bias in my presentation, it just represents my experience of that's been the principal system that I've been using over the last 15 years. Now, we are in the midst of a digital revolution. I don't think anyone would debate that. Everything in our world is turning digital. AI is certainly come along, and some people are anxious that it's going to turn our world on our heads and change everything. Although I feel in dentistry, it's only positive what I've seen of it so far. But as dentists, although many of us have used digital records, some people are using them for recording consultations and all that sort of stuff, we've been slow to allow digital to change the way we actually provide treatment for our patients. Now, having said that, despite us, digital workflows do exist in dentistry, and it's been mainly through our technician colleagues that this digital revolution's been happening. Quietly in the background over the last 10, 15 years, our technician colleagues have moved away from the traditional analog workflows to a much more digital way of presenting things. So they've been able to take our analog inputs, our impressions, our models, scan them in and start using them digitally. And where we've seen the benefit has been the development of new materials, new ways of making restorations, more cost-effective ways of making restorations. But in truth, the full power of digital will only be unleashed once we all start using intraoral scanners and we take the analog element out of the equation and we allow the digital tools to start interacting with one another. And it's when the digital tools start talking to one another that the real magic starts to happen. And I want to try and share a little bit of that with you in our presentation today. Now, if you are using an intraoral scanner, my first question to you is, how are you using your intraoral scanner? Are you basically using it as a very expensive way of taking impressions, as in a digital impression machine? And yes, there are tangible benefits in doing that, but you're probably missing out on the full potential. So if we look at a very straightforward case, and what I'm going to be doing in this presentation is we're going to start with very straightforward cases, and we're gradually going to ramp up the complexity as I show you more and more little digital tips and tricks as we go forward. So for straightforward implant restorations, patient comes to you looking to have their implant restored. You take them in your typical appointment. You start with doing a bit of shade matching, all that sort of stuff, take a few photographs, take your scan body, screw it into place, take your scan, take your reposing scan, record the occlusion, all that sort of stuff. And that has gone from being perhaps a half an hour, 45-minute appointment with lots of impression material and guns, which our patients don't particularly like, to a very swift, very slick 15-minute appointment. So even if you don't do anything else digital, just doing that is a tangible improvement and a much more efficient use of your time. But when it goes to the lab, suddenly things can happen. So most technicians are using digital tools for designing their restorations. The most common one is exocad, and exocad comes with an app called exocad WebView, and what that enables the technician to do is to communicate with you as they design their restoration. So they can share with you the design. You can look at it, you can look at the emergence profile of your restoration, you can examine the restoration in every detail, and then you can interact with your lab to ensure that they're designing the thing that you're looking for. So it allows everything to be much more predictable. And then what's nice is that the restoration you're expecting to get back is exactly what you get back. And because of the extreme precision of these digital techniques, the fit appointment becomes a joy. I mean, it's just a question of unscrewing the healing abutment and screwing the restoration into place. And so again, what might have been a 45-minute appointment to fit an analog-based implant restoration is once again a very efficient 15-minute appointment. So in that way alone, the use of intraoral scanning pays for itself very quickly, but there is much more to it. So if we look at digital workflows, we can use them for treatment planning, both from a point of view of the surgical planning as well as the prosthetic planning. Then it is also a really useful tool for patient communication and consent. It's also very useful, as we just looked at, for laboratory communication. And in addition to that, it is very, very helpful for record keeping, because all of these things that you plan digitally, you automatically have a record of. And then it just makes the delivery of the treatment much more slick and much more efficient than you were able to do in the analog world. And so we're going to explore that in our presentation today. Digital workflows, however, are not a new thing. If people are nervous about it, go, it's all new, and I learned it one way, and I'm not too sure about taking on these new things. Maybe everything hasn't fully worked out. I want to share this case with you. This is a case that I did 27 years ago, and it was the first digital case I ever did. So this is a patient who came to see me with failing upper and lower bridge work, and he came to me at the time and said, I don't care how much it costs or what's involved, but the one thing I want is to never have to wear a denture throughout my treatment. And so in those days, the first of the digital planning software was Implant. And just to put this into perspective, 27 years ago, cone beam CT scans had not been invented. Intraoral scanners had not been invented. 3D printing had not been invented. None of the things that we use today and take for granted had been invented. So we had to send off for a full medical CT scan with all the radiation associated with that, but also with the expense and the time involved in getting that scan. But we were able to plan the case. And you can see from how primitive the graphics are that, this really was the early days of digital. And then once we'd planned the case, the next stage on from Implant was SurgiGuide, where they designed surgical guides for you to help you to carry out the surgery. Now, in those days, as I say, 3D printing wasn't invented yet, so these models were made by stereolithography, which meant they were very expensive. They took a long time to make. So when you sent off one of these cases, it took 3 or 4 weeks to get everything back, partly because there was only one place doing it, which was the Implant headquarters at the University of Leuven in Belgium. And they would then 3D print the models. And you have to remember, in those days, sorry, not 3D print, they would, using stereolithography, create the models. And in those days, all you could do was have bone-supported guides. And so we had these guides made, and you had a different guide for each diameter drill that we used. So in this case, having got this back, we carried out an initial mock-up of the surgery on the actual models themselves. And this enabled me to then get the laboratory to make up a provisional restoration. And again, this was done in an analog way, but we made a gold bar with large spaces to allow for the fact that there may be variation where the abutments are going to be, and that we'd be able to pick that up in the mouth. So we went ahead, did our surgery, went through our various different guides. And one of the biggest downsides of this was because all the guides were bone supported, you had to really raise enormous flaps, nearly sort of deglove the entire maxilla just to get the guides to fit into place. But at the end of it, there's our temporary abutments, and we were able to then pick that up in the mouth, linking the abutments to the provisional framework. This is the provisional restoration after 3 months, and then this was the final restoration. And this final restoration lasted the patient for the rest of their life. So it worked, but it wasn't straightforward to do. There were a lot of limitations with the early guides. There's no relationship between the soft tissues and the guides, so you were forced to use bone-supported guides. And as I said, this required you to raise quite large flaps and big surgical sites. So quite intimidating surgery compared to what we're doing today. Later on, the ability to make tooth-supported guides came along. But there are a few things that are quite different from today. There was no depth control, so that made it quite challenging. How far do you drill? You had multiple guides, so that potentially brought in an inaccuracy where you take off one guide, put another one on. Do you get it in exactly the right spot? And there was no guiding of implant placement. But the biggest drawback to all this was how expensive it was and how much time it took to do this. So this was not something you were going to do for smaller cases. You had to do it for a large case to really justify it. And you had to be quite an experienced surgeon to get this to work, but it did work. So early digital workflows were challenging to use, cumbersome and time-consuming, and very expensive. But thankfully, all of that has changed. So how have digital workflows changed? Well, really, it's the availability of new technologies that has made it much, much more straightforward to implement these techniques. The cone beam CT scanner was probably the first step in that process, invented in 2001. And apart from massively reducing the amount of radiation exposure that you put your patients through, which allowed you to justify using it on a much more regular basis, it still gave you the DICOM data that you needed. And now that they've come down in price so much over the years, now they cost the same as what an OPG used to cost when I first qualified. It now has become the minimum standard of care. When I used to first be involved in teaching implants, we used to be going, well, can you justify taking a cone beam CT scan for this patient? Can it be worth the cost and the exposure and all that? But nowadays, with the reduced exposure and the reduced cost, I think it would be very difficult to justify doing any kind of implant treatment without having consulted a cone beam CT scan to allow you to properly plan the case. It's also a really useful tool to have in your practice, apart from doing implants. So I thought might find this case interesting. This is a patient who came to see me for a second opinion because she'd been told by her dentist that she needed a root canal treatment on her central incisor. And you can see she's got a large draining sinus over her central incisor, but she has no history of trauma to her front teeth. These are virgin teeth. And in fact, if you electrically pulp tested them, all of those anterior teeth are still vital. So I was a bit curious as to see what was going on. So we took a cone beam CT scan, and you can see that, yes, there's a periapical area around the central incisor. So I can see why the dentist was thinking, oh, we need to do a root canal treatment. But then if you look closer, if you look at the picture in the lower left corner, you can see that large periapical area, that radiolucent area, extends distally, and it extends all the way back to the first premolar. And in fact, if we look further back in the scan, we can see there's a very large area around a failing root canal treatment on the premolar. And in fact, bizarrely, the infection is obviously tracked in behind the anterior teeth and has popped out over the central incisor. So whereas one might have rushed in to do root canal treatment on the central incisor, what we did instead was to remove that premolar. And this is a scan. The patient came back 6 months later because she wanted to have an implant to replace that tooth. And if we look at the scan that was taken then, you can see the bone has grown back again, and all around the anterior teeth, there's no area there. It's all come back. And again, it would have been unnecessary to carry out the root canal treatment. So you can see that having access to this three-dimensional information just gives you so much more of an input into what's going on and allows you to avoid unnecessary errors. The other big step forward was the development of intraoral scanners. The first one on the market was the iTero one, and I was fortunate to get one 15 years ago. And although it was big and clunky and quite hard to use, it did create fantastically accurate scans. And in fact, as accurate, if not more accurate, than many, many scanners that are available on the market today. It was just hard work to use. I mean, the handpiece was a very heavy thing, was a big workout, and the software was clunky to use. It was time consuming to use, but it did produce beautiful scans. And then, because 3D printing hadn't been invented yet, the models you got back were these milled models. And again, they were fantastically accurate, and they came with their own little articulator, and they recorded the occlusion really well, and they were very, very accurate. Now, bearing in mind, 15 years ago, the digital techniques, the CAD/CAM milling, etc., that we use today for making restorations didn't exist. So we were building restorations using analog techniques. But despite that, there was still a very dramatic and tangible improvement in the fit and the accuracy of the restorations I was getting back. And suddenly I was able to do things like this, where you have two opposing sextants, and literally in 2 visits, you could go from prep to fit in just 2 visits with minimal adjustment. And that's something you could never have been able to do with an analog workflow. So there was definitely a tangible benefit, even then, with the limitations of the technology that there was, of using intraoral scanners. Nowadays, if you look at the scans, the image quality has improved dramatically. You get these high definition resolution scans where you can see all kinds of detail. And a lot of the scanners now come with all sorts of specific tools to allow you to communicate, particularly with your patients, quite well, and to point out various things. And some of them even come with, at the same time as you're scanning, there's an intraoral camera taking photographs. And this is really, really useful when you sit down with your patient and you're trying to talk them through a case and explain what's going on, being able to show them these images. But then you can also annotate these images, and you can send the patient, or you can put it into the patient's record, but you can also send the patient a copy of this so they can take it away with them, and they've got a record of exactly the things you discussed. And in fact, what I find intriguing about this is I'm a great believer in being able to see things, and if patients will be far more likely to go with treatment if they can see. It's much more tangible to them if they can see something rather than just taking your word for it. And in fact, I found when you're reviewing these scans of patients, the patients are often pushing you away and looking at far more intrigued about the scan than what you have to say, and they start picking up on things and seeing things and asking things about things. And so patients are far more engaged than they are from our sort of more old-fashioned consultation. So this is an incredibly powerful tool, and again, a really, really good way of taking detailed, accurate records. So I would put it to you that, in fact, really to get the best out of your scanner, you should be thinking about scanning every patient for every checkup. Not only does it give you detailed records, both from a photographic point of view, but also in terms of creating an STL file or a 3D file of the patient. And having those on record is really, really useful for many reasons. Not least of which is what happens to your patient if they have an accident at some point. I don't know, they fall over and smash their teeth. Wouldn't it be really useful to be able to have a record of what they started off like? And I will show that to you, an example of that to you in this presentation. But it's really useful for that. But it's also useful for things like monitoring. So one of the features that you get with many scanners is this time-lapse feature where you can superimpose different scans over time and compare the changes. So, you know, that patient who comes in and says, oh, I think my teeth are moving and, you know, I'm really worried about it. And you kind of go, okay, I'm not too sure they are moving, but you can actually show them exactly how much they've moved, if they have moved at all. And often that's very reassuring to patients, or monitoring recession, changes to the gum, all that kind of stuff. So this is really useful to be able to do that. This is information that's just there, sitting there for you, sitting on the cloud and very available. And then, as I've been describing, it's an excellent communication tool in terms of being able to explain what's going on to your patient and getting patient engagement, but also for communication within the dental team. If you're referring it off to, I don't know, your orthodontist or some other member of your team, perhaps the laboratory, and you're wanting to explain what you need to do and what you need them to do, it's really helpful for them to have a scan and to be able to visualize what's going on, particularly when the patient's not present. And then obviously for treatment planning, which we're going to look into in this presentation, this becomes very invaluable. So looking specifically at digital workflows in implant dentistry. Now, as part of this, a key element to this is the concept of prosthetically driven implant dentistry and how guided surgery links in with that. That's a key element to how we use digital workflows in implant dentistry. Now, in order to carry out implant planning with digital technology, we need three things. Okay, so the first thing we need is obviously our cone beam CT scan, which gives us our DICOM file, our three-dimensional radiographic information. Then we need an STL file, which is our intraoral scan, or in the old days before people had intraoral scanners, you could send your model to the, you could take a conventional impression, the lab can pour up a model, and then they can use their lab scanner to create the STL file. Obviously, that's much more clunky and cumbersome and time-consuming to do, but it is possible to do. And then the third element that you need is some form of implant planning software to integrate these two things together. And there are loads of different ones on the market. Some are free, some you pay for, some have more features than others, but they all sort of function on the same general idea. Now, when we compare this with the original analog way of doing things, which was quite cumbersome, you know, if a patient came to you for an implant consultation, at that appointment, yes, you might take some 2D x-rays, you might have a look at the patient, but then you're telling them, okay, well, the next thing we need to do is arrange for cone beam CT scan. But before we do that, we're going to need to take some impressions. We're going to need to get a diagnostic wax up made up. We're going to need to get a radiographic stent made. So all of this is an expense to the patient before they've had anything, before you can even say, is this going to work or not? And then you get all that back. So this is another visit. And then you send the patient away to somewhere to get the scan done. And then eventually you get it all back again. Now, with the advent of all of this digital technology, this has become much, much more slick and has completely transformed the way I do an implant consultation. So when a patient comes to me for an implant consultation on day one, possibly even before it's, well, not necessarily, but often, certainly as part of that initial appointment, we get a cone beam CT scan taken and we get an intraoral scan taken. And so at that appointment, I already have access to these two scans. And so that gets imported into our 3D planning software. And I can already, even just with a quick glimpse at the software, can tell the patient, yes, this is a goer, or no, this isn't, or yes, this is going to be really complex, or it's going to be straightforward. Because what we do with this information is we put the scans together, and already I can see things like, is there going to be a big bony defect? Is this going to involve bone grafting? All this sort of stuff. So you get access to this information very, very quickly. And it makes that initial consultation much more valuable to the patient because they're getting much more information from the outset. It makes them feel much more confident about what's going on rather than just racking up big bills and not actually knowing where they're at. And so I find this very valuable and it's very time efficient. I mean, in a 45-minute appointment, I can gather all of this and I can already, the patient can go away with quite a clear view of exactly what's involved. Let me show you an example. So here's a patient. It's a very straightforward case. They've come in, they've got a failing upper second premolar. on the initial appointment, we've seen the failing tooth. We can see that the tooth is quite close to the sinus, so it may not be the most straightforward implant placement. But our diagnosis is made, the tooth needs to come out. And we're managing this case very conservatively. So we're taking the tooth out, we send the patient away for 6 weeks, and we get them back, and we get our cone beam CT scan taken, and we take another intraoral scan, this time with the healed extraction site. And now we start importing it. And one of the softwares that I use quite a lot is Co-Diagnostics. And this allows me to take the 3D X-ray information, the DICOM file, and then the scan of the patient pre-extraction, post-extraction, and then the opposing model. And I've got all of that information together, and I can put that in the software, and we can start planning our implant placement. Now, you can just do it from the X-ray information. This is a very old school, we put the implant where the bone is. But from a prosthetically driven point of view, wouldn't it be much better to also be able to plan where is the ideal position for the implant with the final restoration in mind, and then link that back to the post-extraction model, which allows us to then start designing a surgical guide. So here's our surgical guide, and this allows us to place the implant exactly where we need it to be able to get the best outcome. Now, you could argue and say, well, with a simple case like this, surely that's over the top. Surely you don't need to do it with guided surgery. And yeah, that's probably very true and very valid. But even if you don't do the guided surgery, just doing it in this technique and having this record, if anyone ever challenges you and says, have you actually properly planned this case? You can pull up all of this information, say, look, this is where I plan to put the implant. I've worked out exactly where the bone is. I've worked out, do I need to do any augmentation? Do I need to do anything? You've got a record of all of that. As it gets more complex and there's a bit more treatment planning and patient communication needed, this is where it all really comes into its own. So this is a case, in fact, I'm just done this case last week, of a patient who came to see me with a failing bridge. We managed to decoronate the upper four as the abutment. So we sectioned the bridge and took that off. And now the patient wants to have a replacement for it. So we took our cone beam CT scan. And in the conventional way of planning this case, you would think, okay, well, we should put an implant in the 4 site and an implant in the 6 site with a view to doing a 3-unit bridge. But as we look at the whole thing in a bit more detail, you can see, yes, if we do an immediate placement in the 4 site, that's straightforward, that's fine. But in the 6 site, there isn't a whole lot of bone. In fact, there's very little native bone. And this is going to require a staged approach. We're going to need to do a sinus lift procedure first, leave that to heal for about 6 months to let the bone grow in before we can do the implant placement. So being able to show that to the patient, explain that to the patient, that this is what's possible if we do that. But then we could also show an alternative option. So being able to show the patient that, yes, if we were perhaps to put 2 implants, and this patient's got kind of unusual anatomy in that you've got this funny little hump of bone in the second premolar position. If we put an implant in the first premolar and an implant in the second premolar position and perhaps leave the 6th site, that would allow us to place the implants, both implants, into native bone. Albeit in the second premolar site, it's quite a slim little site. You need to be very, very careful how the surgery is done. But it is possible to do that without getting involved in complex augmentation. And the patient, being as he was 80 years old, said, look, I'm happy to live with a gap in the 6th site as long as I get those 2 teeth. And then I don't have to go through as invasive a surgery, and the treatment can be done much more quickly. So in that case, we're able to plan it, make our surgical guide. And because the surgery can be very, very accurate, even though you're trying to sharpshoot into a tiny little piece of bone, we're able to get the implants very accurately placed. The point being, this allows for informed consent. The patient was able to see the differences. It was tangible to them what was going on. You were able to communicate to them exactly what was going on, what their options were, and they could make the decision that they felt was most appropriate to themselves. So again, I find this a really invaluable tool from this point of view. Now, if we look at implants in the aesthetic zone, that ramps up the challenge a bit more. Obviously, everything's on site, everything's going to be in view, and the ITI came up with some guidelines as to how to manage it. So they did a consensus statement in 2004 where they reviewed all of the data available at the time, And they came out with what today seems a very obvious statement, and that is that the correct three-dimensional implant placement is essential for an aesthetic treatment outcome. Now, that seems blatantly obvious today, but we need to remember that before 2004, implant surgery was very oral surgeon driven. It was all about put the implant where the bone was, and then you could sort out the restoration thereafter. And it's only once the concept of prosthetically driven implant placement, where you need to put the implant in the correct position for the prosthesis, that the complete mindset changed. And they came out with the concept where deficiencies exist. Instead of putting the implant in the native bone, that you put the implant in the ideal position, and then you carry out the appropriate hard and soft tissue augmentation procedures. And they came out with this traffic light system for describing the optimal position for your implant. So your implant shouldn't be closer than 1.5 millimeters to the adjacent teeth. It should be in the correct buccal palatal position, and it should be in the correct apical coronal position for the particular design of implants. And so this was a crucial statement, and completely changed how we do implants today. And in fact, if you look at the success rates and the survival rates of implants, there is a complete switch in the outcomes from that date onwards. And so this paper, which was published as a follow-up from that, is probably one of the pivotal papers for any implant surgeon to be very well aware of, and completely changed how we went about placing implants. Initially in the aesthetic zone, but in truth, what holds for the aesthetic zone also holds for any other implant placement. So let me give you a description of this. This is a young lady who came to see me, and she came to see me just after COVID. We were all very limited as to when we could see people, how we could see people. I'm sure we all remember that with great fondness, not. But she came to see me because she'd managed to snap off her central incisor, and all it was holding on, the only way it was staying on, was just by the gingiva on the labial aspect. And conventional radiograph shows the tooth is root treated, and you can see the fracture line in it. And obviously she was very concerned, and you can see she is a very high lip line case. So this is going to be a case that's quite challenging to ensure that we create a suitable aesthetic outcome for her. And we need to manage this very, very carefully. Now, the other thing you may or may not notice is in between the roots, there's quite a dark area that, visible in the bone. And that you will see later in the sequence is because she's got quite an unusually large incisive canal. So here she is on day one. I actually bonded back the crown so it wasn't hurting her so much, just to stabilize things. And we took an intraoral scan. You can see, fortunately, she's got a relatively class 2 incisal relationship, so there's a little bit of space for us to work with. And if you switch off the color, you can see more detail like wear facets, crack lines, all that sort of stuff. So day one, stabilized the tooth, took our scans. And that went to the laboratory, and we had an immediate resin bonded bridge made up, cantilevered off the other central incisor, so that when she came back on 2 weeks later for visit 2, we were able to extract the tooth and place the resin bonded bridge. Now, you may be saying, why haven't we done this immediately? But that's to do with this incisive canal, as you'll see shortly. So sent the patient away. Sorry, at that point, we also took an intraoral scan, having just removed the tooth. Then we sent her away for 6 weeks and got her back to take a cone beam CT scan and a new intraoral scan, put them in our software, and started our planning. And as you can see, she has this really quite large incisive canal, which is what prevented us from being able to do an immediate placement, because there's not that much bone around. We need to be quite careful how we place our implant. But again, we take our pre-extraction scan, our scan at the time of the extraction, the opposing model, and our cone beam CT scan, put it all inside the software, and we start planning the case. And you can see we need to put in a relatively small implant. So this is just putting everything together. So we're looking at about an 8 millimeter tapered implant to try and get it into the remaining bone. We need to ensure that it's in the optimal three-dimensional position for the prosthetic outcome, that we can do a screw retained restoration, and we can see from this what bone augmentation, etc., that we're going to need to be able to do on this. But from that, we can then plan our surgical guide. And so here we are, we're now at 12 weeks post-extraction. There's our guide in place, and we're now going to carry out our surgery. And so we're following a guided protocol. Sorry, surgery is speeded up a little bit just so the video isn't too boring, but we run through our sequence of drills. They're guided both for depth and for positioning. And then finally, we guide our implant into place according to our plan. Once the implant is in position, remove the guide and place a scan body. And the reason for placing the scan body is it allows me to take an intraoral scan of the implant position. You can see the flap is raised. What I'm interested in is the relationship between the scan body and the adjacent teeth. And then we go ahead and we do our GBR and everything. We close it all up. And here she is at the end of the appointment. We sutured everything back together, popped our resin bonded bridge back in position, and off she goes. Now, this scan is recording the position of the implant versus the rest of the teeth. You can see the rest of it looks a bit of a mess. But the critical thing is we now know where the implant is. And then what we can do is we can take that scan. This is where the digital world becomes quite interesting. We can take that scan and we can take the scan taken at the time of extraction with the soft tissues where you'd ideally like them to be. And we can join them together in the software. And we can then start designing a provisional restoration based on the ideal shape that we would like to get the soft tissues to be the way we'd like. And so from that, we can have a provisional restoration pre-made while the healing is taking place. And if anything, I've slightly under-contoured the restoration so that I have the ability to then start pushing the tissues once we fit the provisional restoration. So here's our patient, 12 weeks post-surgery. We pop off the resin bonded bridge. And because we've done it guided, we can pop our surgical guide into place, and X marks the spot in terms of where the implant is. So I know exactly where to make a tiny little incision to expose the top of the implant. And I can then expose the implant and switch from the closure screw to a healing abutment. You can see we're starting to push the tissues a bit there, where it's blanched a little bit. And then we can fit our provisional restoration. And it doesn't look great at the moment, but without doing anything, just letting it sit and relax and having a restoration of the right shape, 2 weeks later, that's what the soft tissues look like. So the soft tissues respond to that shape and recover nicely and come back into the ideal shape. Then we let it mature a little bit, let it settle down. But when we want to make the final restoration, we obviously want to copy that shape into the definitive restoration. So how do we do that? Now, if you look at the literature, there are a variety of techniques described. But the one that I find most predictable is this one called the triple scan technique. Now, if you look at this diagram, it's very confusing and hard to follow. So instead of concentrating on that, let me demonstrate it to you. So here is our a scan of the patient with the provisional restoration in place. And then we unscrew the provisional restoration and we take a scan of that outside the patient's mouth. And we follow that up with a new fixture head level impression. And then what the software can do is to put all of that together so that we have the provisional restoration with its emergence profile recorded together with the fixture head level impression. So that everything gets put together. And this enables the laboratory to then create a restoration with the ideal emergence profile that we've spent so much time working on. And so here is our finished restoration. See, there's our postoperative X-ray. And there's our happy patient who, despite her high smile line and everything, we've managed to maintain the soft tissues as well as the hard tissues and all that. So taking a very, very careful approach in a challenging case, but the digital tools have helped us enormously in doing that. Here's another case. Patient of mine, happens a lot in London, came off his bicycle, hit one of those many potholes that we have these days, and has smashed his front teeth. The left center actually came out fully, and he had phoned me the night before from A&E going, what do I do? And I said, make sure you put it back in. But he sort of wimped out a little bit and didn't get it back in fully in place. So you can see it's completely out of place. There is a subluxation injury on the right central incisor as well as it being fractured. So it was quite about grade 3 mobile. So this is him 24 hours after his accident, once he was discharged from A&E. And we took a cone beam CT scan. Unfortunately, because he completely knocked out the tooth, he managed to preserve the buccal plate. You can see on the right central, you can see the widening of the periodontal space where that's been traumatized. So as our initial emergency treatment, we splinted the right central, or we built up the right central and composite back to its original shape, and then we splinted it to the adjacent teeth. Took an intraoral scan of that. And then the question is, well, how do we start rebuilding this? Now, fortunately, I happen to have a scan of his teeth from before his accident. So at least I had a starting point of knowing where the teeth were and what I was trying to do. So we took these two scans, combined with the cone beam CT scan, and fed that into our software. So here is the DICOM information. There is the intraoral scan taken at the time of the accident. And this is an example of where AI I find is really useful, is when you put the scan into the co-diagnostic software, you can now do virtual extraction. So we can take out the tooth and see what the underlying bone is like, what the condition of the buccal plate is, and we can start planning exactly where we'd want to put the implant and what bone augmentation, etc., would be required. And from that, we can, as I say, work out the optimal implant position despite where the tooth is. And then this is using this is an alternative to code diagnostics. This is RealGuide, which is the software that my lab quite likes to use. And from that, we're able to design our surgical guide. But we're also able to have a provisional restoration made up with the tooth in its optimal position. So a week after the accident, I got the patient back in again. We extracted his central incisor, placed the implant in the optimal position, put a temporary abutment on it, and we were able to build our temporary restoration. We also carried out a bit of hard and soft tissue grafting around the site, but that's the immediate post-operative picture. And there's our post-operative radiograph. And here is the patient 6 weeks later. And we're reviewing the splinting. We take off the splint, carry out some pulp testing. We found that the right central incisor, not surprisingly, is non-vital. So I went ahead and carried out a little bit of root canal treatment on that tooth to manage that. And here is the patient 6 weeks after that. And he's looking to have his final restorations. Now, he feels that his central incisor, the right central incisor, is starting to get discolored. So he's quite keen that at the same time as restoring his implant, that we restore the other tooth as well and have them as a matching pair. So I go ahead, we do a little bit of shade matching. I prepare the right central for his zirconia crown, and we unscrew the restoration on the implant and place our scan body. And then exactly the same way as with the previous case, we carry out the triple scan technique to record the emergence profile. So again, we have the scan of our provisional restoration, the fixture head level scan, and the scan of the provisional outside of the patient's mouth. We put the three together. Now, one of the things I found to make it more efficient to take those scans is I made up these little stands, because I found if it's on a stand and it's not moving around, it's much easier to scan them. So that's, again, if a practical tip, if you want to be able to take intraoral scans of restoration or extraoral scans of implant restorations, make yourself up a little stands using an analog appropriate for the particular implant, and it just it makes the scanning process much more quick and much more efficient. And then when it came to rebuilding this tooth, so sorry, just to show what the lab does in terms of matching this up. So they will take the scan of the provisional restoration in the patient's mouth and it outside of the patient's mouth, and they'll find the points of commonality. And then by doing that very cleverly, the software is able to blend the two things together. And then in a similar way, you blend in the scan with the preps on it. So there you have the emergence profile, and then that can be transferred over to the prep scan as well. And you can see the emergence profile, how it's recorded, and copy that into the final restoration. Now, the other thing that we did in this case was, because we had a pre-op scan and we knew we wanted to get as close to what the patient's original dentition was like, we're able to, in exactly the same way, introduce that scan into it by finding the same points of commonality and letting the software put that all together. And so at the end of it, we had designed our restorations, copying the pre-op, and then we can do the cutback and we can check everything. And then the nice thing is with WebView, the lab can share that with me so that I'm happy that we have the correct emergence profile, we have the correct amount of labial cutback, and so it's all going to be predictable. So here is our final plan. You can see it's a direct copy of the provisional. You can see you've got the same emergence profile that we had in the provisional. And then these are the final restorations. And because it's all been done in a very predictable way, it's a very simple screw retained restoration. And these are the restorations at the time of fitting, no adjustment required, no nothing. You just screw it into place. You can see a little bit of blanching in the tissues. There's our immediate post-operative radiograph. And here's the patient a couple of months later when it's all had a chance to settle in nicely. And this is just, again, a very predictable way of getting from what was quite a traumatic accident to what the patient is very happy with. Now, one of the challenges for us is, how do we reduce the complications in digital workflows? If you're going to transfer over to something new, how can you reduce the complications? And we as the dentists get the blame. The root cause of is an operator issue. And I'm afraid with digital, that probably is quite true. Most of the issues when I'm in the lab and I'm looking at things that go wrong are to do with the scans not being done properly. So I thought it might be useful to spend a little bit of time looking at how do we get the best scans and what's involved with doing that. And to help us with that, I'm going to look at the consensus statement that came out in 2018 on accuracy of different impression techniques. Now, you might say 2018, that's a long time ago, that's 8 years ago, but actually, and the technologies have moved on vastly from then, but actually the points raised in that meeting, I think, are very important points to consider when you are planning to use intraoral scanners. So let's look at the first point. So the first point they made was that the accuracy of digital impressions with intraoral scanners for single or adjacent implants, and so in small spaces, basically, is just as accurate as analog techniques. So, with a scanner doing a single tooth restoration, you're perfectly fine using an intraoral scanner. There are no issues with that. And so that was agreed in 2018, and as scanners have improved and everything, that's even more valid today. However, there are a few things you need to be aware of. So if I go back to this, there's a few things you need to be aware of and a few little pitfalls. And one of the weak links in all of this is, how is the model made? So it's important that you are aware of what protocols the laboratory's following, because this is something that can go wrong. So let me show you a scenario that arose recently for me, where I took a scan for replacing an upper left 6. Scan was fine. But when the model came back with the restoration on it, I looked at that one, hang on a minute. How come I can see the abutment? How come I can see what's going on here? Something's gone wrong. And one of the mistakes that can be made is when you 3D print a model, you then have to manually place the analog into the model. And if the technician's made a mistake and hasn't seated it perfectly, then you can get mistakes like this. Now, in an ideal world, you shouldn't actually be basing the design of your restoration from a model. You should be using the digital data in the first place. So that's number one. In terms of protocols, is your lab using the digital data, or are they scanning them? Are they taking that digital data, printing a model, and then rescanning that, which introduces a lot of potential errors? Even if they are going to use a model, though, are they then going to follow a protocol that allows them to check the accuracy of that model? So what you want to try and do is avoid compounding errors, because every time you introduce an analog step, such as a person putting an analog into the model, or anywhere where you're stepping out of the raw digital information, there is a potential to introduce an error. So when possible, use the raw digital data. But if you are going to print a model, then what the lab should be doing is taking a scan of that model, and a little bit like we did in the previous case, you should be superimposing that back into the digital information. And then what you can do with the scanner, with that, is on the software, you can then check and make sure that it is all fitting back together accurately, and that the analog is in exactly the position that it was in the raw digital data. And a lot of labs don't do this step, and then potentially you have an error. So that's one of the things you need to have a discussion with your technician. Say, are you doing this? Are you rechecking it? It's a bit of faff, it's a bit of extra thing, but it's much better than you getting the thing back at the chair side and going, well, it doesn't fit. And then we have to rescan it, redo, and it wastes a whole lot of your time, and your time's much more expensive than their time. So make sure you've got the right protocols in place and the lab has the right protocols. Then we look at it. One of the statements that came out in this study was that the accuracy of digital impressions is negatively influenced by the inter-implant span. So if you're doing bridge work with implants, the further apart the scan bodies are, the potential for the inaccuracy. Now, I would argue that with newer scanners, that's less of an issue, but if we think back to our analog workflows, we'd never have dreamt of making a big bridge on 2 implants without first verifying the accuracy of the cast. And so these techniques that we learned in the analog world are still valid in the digital world. So it's really important when we're making bridge work that we always use verification jigs. So with short span bridges, so let me give you an example. Here's a case I was working on, and we've got 2 3-unit bridges. In fact, we've got some cantilever bridges in the front. And what we've done is we've taken an intraoral scan with our scan bodies. The lab has printed up some models, but then they make me some verification jigs. Okay. Now, depending on the complexity of it, whether you get them to make a solid verification jig or a sectioned one, probably for 2 implants, you're okay with a solid one. When it gets more complex, as I'll show you later, having a section jig works better. And you screw those into place and you make sure they fit passively. So that verifies the accuracy of your models, but also gives you an opportunity to have another check that the occlusion has been recorded properly and the models have been properly mounted. So it's always good to have lots of checks and cross balances, because it then means the laboratory can, having verified the accuracy of the casts and the accuracy of the occlusal record, they can go ahead and design the restorations. And then once they've made the final restorations, it then takes all the faff out of it, because it's just a question of fitting them. I mean, I was able to fit all of these restorations in one hit with no adjustment or anything, which in the analog workflow would be unimaginable. But with the digital workflows, once you've done all those little checks and balances, it becomes a very predictable thing. So statement 3. Now, this is a really important one to bear in mind. And that is that the scanning protocol using intraoral scanners is significantly influences the accuracy of the scan. Now, what I mean by that is each different scanner, different brand of scanner, has a different scanning protocol. And one of the biggest sources of complications and issues is if you've got a dentist who works in a variety of different practices and uses different scanners, and they go, oh, well, it's all the same. It's just using a scanner. And that's when people get into no end of difficulty and they have all sorts of problems generating scans. Now, with the newest generation of scanners, they're a little bit more forgiving, but it is important that you follow the scanning protocol and the scanning sequence for the particular scanner that you use, because that's how the software knows how to track all the images and put them all together. And so if you do something that's different, you'll just get a confused computer and it won't put things together properly. So as I say, it's particularly challenging if you use different brands of scanners because you have to change how you're doing things for each one. But it is actually, without wanting to sound pedantic, it is actually a really important point. And that's where I keep getting phone calls from the lab going, what has this person done wrong? Why are we having problems viewing this scan? And it's inevitably because they've gone from one brand to another. So it's important that you know the scanning protocol for the particular scanner that you're using and you follow that. Final one, which is, the fourth point, which is that one that'll upset people a bit is, and that is that there is a significant difference in the accuracy between different intraoral scanners. You know, each brand of scanner, when you look at if you go to a trade show and you get lots of different scanners, everyone's going to tell you that their scanner is the most amazingly beautiful scanner and is better than everybody else's and costs a quarter of the price of everybody else's, and they put down everyone else's scanner. The truth of the matter is there is a difference between scanners. And the only way you're going to get a straight answer, in my opinion, is to talk to the technician that you're using, who gets scans in from all the different scanner brands and will actually be able to tell you that, yes, brand X does, and it is that tangibly different, that brand X does better scans than others. So my one piece of advice to you is don't listen to your friends. They've just spent a fortune on their scanner. So of course they're going to think that their one is the best. Don't listen to them. Don't listen to the sales reps because they just want to sell you something. Is actually talk to the labs and say, look, which scanner consistently gives the most consistent scans that require the least amount of messing around from your point of view to get predictable results. And they will give you a straight answer. They will tell you, and that's valuable information to you. It is true to say that we're at an interesting time and that we've got a whole new generation of scanners coming out. The iTero Lumina, without wanting to plug, but is an example of that. Shining, which is a Chinese brand, have come out with a new one. They're all coming out with this new technology, which has multiple scan heads on it, and that definitely is a significant leap forward. So the newer generation of scanners, of which, as I say, there are only a couple of them on the market yet, but I reckon in the next year or so there's going to be a mass explosion of them. Those are significantly better and more accurate and easier to use than previous generations of scanners. So, as a summary to that, in this consensus statement, they came out with some clinical recommendations. And so, as we said already, the use of digital impressions for single implant restorations can certainly be recommended and is very, very straightforward. And as I showed you earlier in the presentation, saves you a huge amount of time. And yeah, I can't but recommend that. It is important that you follow the correct scanning protocol for the particular scanner that you're using. The use of scan bodies is recommended. I mean, that's kind of self-evident and self-obvious. I mean, you wouldn't take an analog implant impression without putting an impression coping on. So why would you think you wouldn't need a scan body? Although I have one thing to say about scan bodies, and that is you need to be certain that you're using the correct scan body for your implant, but also that it's the correct scan body that your laboratory can read on their software. So what do I mean by that? So I'll give you an example. I had a patient come into me. They had a Zimmer implant. done in Germany, and they needed a new restoration. So I dutifully went off and ordered the Zimmer scan body, scanned that in. The lab got back to me and said, sorry, our software can't read this. It just does not compute on this. So I had to say to the lab, okay, well, what scan body can you use? And they gave me the details of the correct scan body that fitted in with their library. So you need to have one that's compatible with the laboratory software, but then also fits correctly on the implant. So there are companies, New Anchorvis being an example of it, that will make scan bodies for every possible type of implant on the market. And if your lab has the New Anchorvis libraries, they can then use that for interpreting the scan. One of the things, if you're using Straumann and you're using the new TorqueFit connection, you need to be quite careful with that connection, because there are two different scan bodies, one for the tissue level implants and one for the bone level implants. And although the connection is the same, so both of them will fit on top of the implant, they're quite different. So here's an example of a case where I personally made a mistake, and it was a bone level implant, and I put a tissue level scan body. In A, you can see it's only a short little bit sticking out above the tissues, so the chances of getting an accurate scan were quite low. But also I needed to make sure the lab didn't get confused with all of that. So that's something you need to be quite careful of and not make that mistake. Now, going back to the clinical recommendations. The fourth one is digital impressions of large inter-implant spans are not yet recommended for routine clinical use. I would say that was the case 8 years ago. Nowadays, as the technology's moved on, we can do it, but there are certain caveats. And certainly in that time, the use of it for edentulous scans couldn't be recommended. I think that's changed now, but in both cases, we need to be looking at the use of verification jigs. So I wanted to, as we come towards the end of this presentation, have a little look at what we're doing with full arch bridges and some of the areas where we're coming at the limits of what digital can do and how we might get around some of these issues. So this is a patient who came to see me. He was wearing a nearly full denture on the top. He just had one tooth, and he didn't like wearing the denture, and he was wondering, could he have an option to this? So this is his denture. And you get a little bit concerned with these cases when actually the denture they have fits really quite well, and you're thinking, crikey, am I actually going to be able to improve on this? But how do we go about putting someone like this, who's got very few teeth, into our digital workflows? So here's a scan that we took at the initial appointment. And I did this case a few years ago, so you can see the graphics of the scans aren't brilliant. So we took a scan of his jaw without the denture. We recorded the occlusion. We took a scan with the denture in place. And you can see one of the issues that comes up is if someone's got a chrome cobalt denture, it can actually be quite hard to scan the shiny metal parts. But we took this as our initial scan. And I also then took a scan of his denture outside of his mouth. And to make it a little bit easier to scan the shiny metal part, you can see it's turned pink. And it's turned pink because I've put some spray on it to make the shiny surface opaque. Now, to do this, you can get specific scan sprays, but most of us probably aren't doing it enough to justify this. But I found if you use a Occlude spray, which puts a very fine layer of powder on the surface, that gets you out of these issues and makes it much easier to scan very shiny metal things. And so we then printed a copy of his denture, and we brought that back. So on the second appointment, we got him in, and we stuck a bunch of little radiographic markers on the denture. So I found these really useful. These are called CT spots. They're come from radiotherapy, but they're little radiographic markers that you can stick onto the surface of things. They're little stickers with little balls. Stuck those on, and then I did a reline impression of the copy denture just to make sure it fits perfectly. And then we took an intraoral scan of that in place with the markers. And then we took a cone beam CT scan. You can see the printed copy of the denture doesn't show up on the scan, but the balls do. We also took a CT scan, although I think nowadays it's probably unnecessary, of the actual denture outside of the patient's mouth. But what's more important is that we have a scan taken with the intraoral scanner of the denture outside the patient's mouth. So we now have scan of the copy denture in the patient's mouth, scan of it outside the mouth, and a cone beam CT scan of the denture in the patient's mouth. And that allows you to put all of that together because you can mark up the dots. That's the points of commonality, similar to where I showed you in the previous cases where we're joining the scans together. And then we can start planning what way we'd like our restoration to be and where we'd like the implants to be. And so again, this is using the RealGuide software. And this enables us to then, we did a little bit of a try and work out the optimal tooth positions and that we've got adequate lip support and the OVD is correct. And again, another opportunity to correct the occlusion or record the occlusion. And at the end of this exercise, we have our surgical guide. We have a full denture, and I make a full denture just in case things go horribly wrong and we can't do an immediate load for them. And then we have a little guide as to where we might want to help us in positioning our abutments to go on top of our implants. And then if you do these cases with Straumann, they send you this big box of tricks with every abutment and everything that you might need to use to go on top of your implants. So we went ahead, took out his remaining tooth, placed our guide, and placed our implants according to our plan. And then we put our little multi-unit abutments in place. And we were then able to convert from the full denture over to an immediate prosthesis, having picked up the abutments with our temporary abutments. So that's our immediate post-operative radiograph. And this is our patient with his provisional restoration in place. So we've got him back 12 weeks later, and we take an intraoral scan of the provisional restoration in place. And we record the occlusion, etc. But then we also unscrew the restoration and we put scan bodies on and we take an abutment level scan. And here's our scan. Now the question is, can you trust this scan and can it be accurate? And based on a lot of the studies, the suggestion is that this scan probably isn't accurate. And so I work on the assumption that this is not going to be an accurate scan. And so we need to make a verification jig. But with these big cases, it's quite hard to see whether your verification jig is actually going to sit down passively enough. So particularly when there's soft tissues and cheeks and everything in the way. So what I recommend doing is get the lab to make their verification jig, but then they section it into little pieces. And I also get them to make a special tray to go over the top. And so what I do is I fit the pieces in place into the patient's mouth, and then I join them all together using Unifast LC, which is a light cured acrylic. And that enables me, and it's important that the gaps between each section are very, very small, so you're not putting in too much material and you don't get any issues with shrinkage. But it means once it's all joined together, I know that I definitely have a passive jig that fits passively on top of my analogs, or sorry, top of my abutments. And then I take an impression over the top with my special tray. And so we then get a master model, which I know has been verified. I also, at that point, take a scan of the provisional restoration and get that printed up so that I can then fit that on our master model. And when I get it back into the patient's mouth, I can recheck the occlusion and the articulation. And that allows us to go ahead and start designing the final restoration. So this is our tooth try-in, just making sure that's all right. And then having planned everything digitally and having planned where I want the implants to be from the outset, we're then in a position to design the framework for our final restoration. You can see the screw access holes are all in ideal positions because we planned it from the outset. And this is our zirconia framework before putting on the layering porcelain. And again, going back a little bit to our analog mindset of wanting to verify everything, we just try that in the patient's mouth, make sure it all fits perfectly. And again, another opportunity to recheck that we've got the occlusion right before the final layering. And that's our final restoration. We can get into the finer detail of how that connects to the implants and stuff like that. There's a bit of controversy in there. But that's our final restoration of the patient's mouth, and we've got a happy patient. And again, always have scans of that just in case something happens. But the beauty is with the digital workflows is if he does break his final restoration, the lab has all of this information and they can easily make a replacement restoration without having to go through all those steps all over again. Now, this case was done a few years ago and things have moved on a little bit. So how do we ensure the photogram, the accuracy of it? Well, one thing that's come along is photogrammetry. Now, photogrammetry needs to be used in conjunction with intraoral scans, and it's a two-dimensional way of accurately recording the positions of the implants relative to one another. And it's incredibly accurate and works really well, and it's really expensive. I mean, you're talking 20, 30 grand at least for one of these devices. So you need to be doing an awful lot of these cases to justify having one of these. And in truth, with the new generation of scanners, I think this has become a little bit obsolete. I don't think we actually need to use these anymore. So people have been coming up with other ideas of how to get round the issues with this lack of landmarks and the challenge of scanning implants that are far away from one another. So one of the techniques that came up is this thing of the scan ladder. And the scan ladder consists of these scan bodies that are like little cantilever arms. And the idea of them is that you bring them all together so that there aren't spaces in between the scan bodies, and so there's less potential for inaccuracy in the scans. However, this one was a bit clunky to use, and again has probably been slightly superseded by this new generation of scanners, which can, without the use of anything, they're claiming can create scans that don't need verification jigs. Now, I think that's a step too far, but I do think there is definitely an increased accuracy in the scans. So if you compare, this is a scan of a full arch taken with a new generation scanner, and this is the traditional scan. And you can see that the quality of the scan, is way different. And it's a much more tangible scan. But I still think you should be doing something to verify the accuracy of things. So Straumann have come up with this kit called the Exact Kit. And what it consists of is a new generation of abutments that are of scan bodies that go on top of your multi-unit abutment. And they're quite interesting in that they've got these little flanges on them. They've much more detail on them for the scanner to pick up on, which allows for more accurate scanning. And then they have these little plastic pieces that are a bit like, it's like something designed by Lego. It's a bit like Lego pieces that clip into place. And the idea of them is that once you place the scan bodies on the implants, you then link them together with these little Lego pieces. And then you join them with a little bit of composite. And then so you have a continuous surface that you're scanning as you scan. Now, let me give you an example of how that works now and how I do things nowadays. So here's a patient who's come to me. He's had his full arch immediate restoration in place for 3 months. We take an intraoral scan of the opposing teeth, and the bridge itself, and record the occlusion. And then we unscrew the restoration and we place these scan bodies in place. And again, because of the scanning sequence, we can record how that comes into occlusion. And sorry, I played around with the Lego bits and I found they didn't actually help very much. But just these scan bodies alone allow you to scan so much more accurately than we were able to scan before. And so this is our master scan. This is our scan with our provisional restoration in place. And we can start designing our try-in of what we want our final restoration to be. And so the change in mindset of this is, because I've got much more faith in this scan, instead of assuming the scan is wrong, I'm assuming it's correct. And so I'm going ahead and I'm designing a try-in, but I'm also designing a verification jig. So I haven't gone beyond but I've much more confidence that it's actually going to be correct. And so instead of having a sectioned acrylic jig, what you can design on the software is a digital jig, and that's partly because these scan bodies are open scan bodies. So a lot of scan bodies force you to make a model. This one allows you to start designing straight from the digital data. And so you could design a verification jig, which then gets printed in aluminium. Sorry, milled in aluminium. So we've got this aluminium. So at the end of, before visit 2, we have an aluminium verification jig and we have a tooth try-in ready to go. And one of the advantages of these aluminium try-in jigs is they're much easier to see whether they're sitting down properly on the patient. And radiographically, you get these very clean radiographs, so you can see for certain whether it's all fitting down perfectly or not. So having verified the accuracy of the scan, I then do my try-in and I check all aspects of it. The patient's happy with the appearance, the OVD's right, lip support's right, all that sort of stuff. And then that allows us to go straight to visit 3. So the lab, that comes back to the lab. They start designing their titanium framework, then the zirconia framework to go over the top of that. And then that's our final restoration, which is a zirconia build up on top of a titanium framework. And then on visit 3, it's just a question of screwing the restoration into place. And we take our post-operative radiographs just to verify that everything's fitting together perfectly. And again, our scans so that we have a record of everything should anything happen in the future. And there's our final clinical photograph. Moving forwards, there are new techniques coming out to even try and eliminate completely the use of the verification jig. And so this is one made by New Ankervis, and it's a bit like a development on from the scan ladder. It consists of these little cantilever scan bodies, and the idea of it is that you bring them all together so they meet in the middle, and so there is very small distance between the scan bodies. And this is to get around the limitations. Again, I think with the newer generation, it's not as essential, but with the previous generation, to get rid of some of the limitations of older scanners by taking that issue of inter-implant distance out of the equation. So the sequence with this is you initially take a conventional scan of the soft tissues and everything with using ordinary scan bodies, and then you place these cantilever scan flags in place. And the idea of it is you take at least 3 scans, and the software then verifies that they are the same as one another. And provided they're the same as one another, the system gives you the green light to go ahead. And then you also they have these little scan bodies that you can put in place on your provisional restoration so that you can scan that. And with that protocol, they are happy to go ahead and mill you your final framework. So they view this multiple scans with their little scan bodies as the same as doing a verification jig, and they will guarantee the fit of the prosthesis that's built on that. So that's only very new out, and we'll see if that actually really works out. But it's sort of the new thing that people are trying. So just to conclude, asking you, are you getting the most out of your scanner if you have a scanner? I hope I've given you a few ideas as to how you might use it a bit more. Digital workflows are very well established and are a matter of life now. They certainly allow you to work much more efficiently, and they allow you to work much more predictably than we were ever able to do before. They facilitate communication, both with your patient and with the laboratory. All dental labs today are digital. And so you're allowing yourself to integrate directly into their digital workflows. It gives you digital records of everything, both to prove your planning, prove all the steps that you've done, and also to be able to go back should anything change in the future. If you need to redo restorations or anything, you've got all of that information to hand. And it's not taking up space. It's all in the cloud, accessible without actually having to have a physical thing that you can get lost. But I think it's important that we don't forget the checks and balances that we learned from the analog workflows. They're still valid today. And it's good to gain an understanding of the protocols and workflows that your laboratory is using to help make sure that steps aren't being missed and mistakes aren't being made. So thank you for all your attention. Yeah, I am very happy to answer any questions that people might have.
Thank you, Owen. Thank you. That was really interesting, really fascinating. Thank you. I've got a few questions that come through for us. So first one is, what do you write on your prosthetic prescription for your lab for the final restorations?
So, so the nice thing is with the digital workflows, it does a lot of this for you because you have to fill in a prescription in order to be able to do the scan. You have to fill in a prescription um, within the software. So you need to give all the information as to what implant it is, what type of restoration you want, what type of materials you want. One of the nice things, which I didn't show in this, but one of the nice things is with the software, or with some of them at least, you're able to take all your intraoral photographs and you can send that with the scan. It all becomes part of the package of information that you send to the laboratory. So basically, I tend to give, I'm a believer in giving the laboratory as much information as possible um, whenever I'm sending them cases. So more information, the better, really. Sorry, Alan, you're muted there.
Sorry. Next question. Sorry, for clinicians who are new to digital workflows, where's the best place to start without feeling overwhelmed?
Um, so first place to start is having a discussion with your laboratory. As I alluded to, they'll give you a lot of advice as to what kind of a scanner you should use and how they integrate it into things. So I think it's important to have an idea of where they're going with things. I would then start with by just scanning patients. Maybe not necessarily restorative scans initially, just even for study models, just to get the hang of it. Um, and then it's just really a case of the more you scan, the better you get at doing it. So I would encourage you to do that. But I think the important thing is to work closely with the laboratory and get an understanding of what it is they need, um, and how you can get that to them. I think that interaction is important. I think if you go off on your own, like the biggest mistake anyone can make is to rush off, buy a scanner without consulting the lab. Um, you might buy one that's completely useless. You might buy one that's good, but you're taking a gamble. You're spending a lot of money on something that's a bit of a gamble. And I've so many times I've heard frustrated lab technicians going, "Oh, this dentist went and bought this scanner. It's not compatible with any of the software that we have. It doesn't fit in with how we're doing things." And then it just creates frustration. And then you get disappointed because you don't get the results you're expecting and you've spent a whole lot of money and all that kind of stuff. So I think step one is definitely have the conversation with your laboratory.
Excellent. Thank you. You actually answered my next question, which was what are the most common mistakes? So you've answered that. The last one for now, I think. How do you decide when a fully digital workflow is appropriate and when a conventional or hybrid approach may still be better, if at all?
So, as things stand today, I probably would default always to a digital workflow until I run into a problem, would be how I'd put it. And then I would view the analog workflows as my get out of jail card if I've run into a difficulty with the digital.
Excellent. Okay. Thank you. Is anybody
Sorry, it does
anyone?
highlight one thing though. Um, a lot of the guided surgery, a lot of all this sort of new technology um, gets pushed by the implant manufacturers um, as a shortcut to proper training. And oh, this is easier. You don't need to know so much to be able to do this. And I think that's one way of getting yourself into deep water very quickly. So these digital techniques are there to augment and facilitate what you do, but you still need to have been properly trained. You still need to know what to do when things don't go quite to plan. So uh, it isn't a shortcut to getting your knowledge of implant. I still think you need to go through your proper training pathways and you still need to know what you're doing. Because there are times when it can throw you a curveball and something doesn't quite work out the way it's planned, and you need to be able to identify that and know what to do to correct that. So I put that in as one big caveat with all of this digital stuff is it's not a shortcut to knowledge.
Excellent. That's really good advice as well. Thank you. Thank you. I think that's all the questions we have for now. So just to say, Owen, thank you for that. That was, as I say, it was fascinating. And thank you also to the audience for your time this morning. This recording will be available to view again from next week, and you'll shortly receive a feedback form, which if you complete, we'll send you your CPD certificate. So thank you everybody for today, and hopefully see you again soon.
Thank you, and good luck with your digital journey.